Good morning, dear students. Today's topic is needlestick injury in healthcare workers. So this is the competency number. So all these points are taken from Apurva Shankar Shastri book. I would like to acknowledge. So no extra thing is added. Same points I will be explaining. So what do you mean by occupational exposure? Percutaneous injury or splash injury, contact with the mucous membrane on or intact skin, or prolonged exposure to intact skin. The agent transmitted is hepatitis B virus, hepatitis C virus, and HIV. The efficacy of transmission or risk of transmission is 30% for hepatitis B. For HCV, it is 3%, and for HIV, risk of transmission is 0.3%. So, which of the infectious specimens, blood, genital secretions, and body fluids, they are considered as potentially infectious? But it should be also clear that which are not considered to be potential infectious. So, feces, nasal secretions, saliva, sputum, sweat, tears, urine, and vomitus are usually not considered as potentially infectious. Which factor decide the transmission? So there are various factors. The type of needle, hollow bore versus solid needle. Hollow bore needle is contains some more amount of blood, so it is considered to be more potentially infectious than the solid bore needle, and therefore history taking when the healthcare workers comes to the infection control officer asking the history of this finger prick because of which type of needle will give some clue what about the risk of transmission. Then if the device is visibly contaminated, if the device is having blood on it or fluid on it, so it again more chances of infection, depth of injury, more the damage, more the chances of infection, volume of blood, if more volume of blood, more chances of infection in the healthcare workers, viral load present at the time. So when the source on which the needle was prior used is having higher viral load, the risk of transmission is more. Then timely performing first aid. If first aid is timely performed, the transmission drastically reduces. Then timely start appropriate post-exposure prophylaxis. So these are all factors which decide the risk of transmission. Then what are the ways to for the prevention of needle stick injury? Standard precautions must be followed at all situations and all. Assume all the patient specimens are potentially infectious. Work surfaces should be frequently disinfected with a 0.5% sodium hypochlorite solution. The hepatitis B vaccination for healthcare workers is mandatory. Some institutes will ask for the hepatitis B certificate, vaccination certificate for the healthcare workers. Then proper spill management, all the wards or all the places in the hospital should have spill management kit, and all the healthcare workers, especially housekeeping staff, should be trained in the spill management if some suddenly some spill occurs. Then use of disposable needles. Nowadays we are using disposable needles. Old days they used to have the reusable needles. So now this is totally stopped. No use of disposable needles should be there. They never cap the needles. So there is a human tendency that they will try to recap the needles, and from the recapping of the needles, there will be the more chances of finger prick. Then disposal after use, all the things which are there, it should be properly disposed. Needles should be properly disposed immediately so that other persons should also not get the finger prick. Then engineering control measures like retractable lancets, safety lock syringe, and needleless IV systems. So all these are the engineering control measures, the devices which are being designed to prevent the needle stick injury. Then precutaneous precautions during the surgical procedures, passing sharp instruments. So there should be non-touch approach. So whenever sharp is passed, it should not be passed directly. It should be put in the kidney tray, and that kidney tray should be passed. Then sutures, needle should not be picked up by fingers while suturing. Forceps for needle holding forceps should be used. Needle holder should be used, and which is ideal for holding the needle. Then preoperative testing is not mandatory. All of you please remember, preoperative testing is not mandatory and should be performed only if the clinical indication is present. But again, it depends upon the institute because of the safety measures. The clinicians also emphasize the need of doing the preoperative test for HIV, HBs, GHCV. So it depends, but actually, as per the government guidelines, the testing unnecessarily without any clinical indication is not necessary. So therefore, it should be properly evaluated if it is really necessary. And then how should safeguard our healthcare workers? Potentially, we should assume all the patients as potentially infectious, and we should take the appropriate precautions, barrier precautions, using personal protective equipments for during performing any surgeries. Then, if you are performing surgery on the patient infected with blood-borne viruses, all the staff, all the members who are involved in the surgery should be aware of the about the fact that this particular patient is having this particular infection. All operating and assistant teams should wear the gloves. The surgical team should involve only essential members and trained in the situation. Trained staff should be employed. The cases may be posted last in the list, followed by decontamination measures. Then post-exposure management. So these are the various points one by one we are going to see in the further slides. First aid should be given. Compulsorily first aid should be given. Report to the designated nodal center. Take first dose of post-exposure prophylaxis, testing for blood-borne viruses. Then decision for post-exposure prophylaxis for HIV and hepatitis B. Documentation and recording of exposure. Informed consent and counseling. Follow-up testing of healthcare workers and precautions during the follow-up period. So these are the point-wise. Then further there will be explanation, point-wise explanation of post-exposure management. Then first aid. First aid do's and don'ts are given in this slide. Earlier, the first aid lesser the chance of infection. So it is a responsibility of the healthcare workers who suffers from needle-stick injury to immediately report to the higher authority to take appropriate action, take further guidance for the steps to be taken after the needle stick injury. Irrigate, irrigate the wound thoroughly, the eyes, site or exposed area, and it should be washed thoroughly, vigorously with water at least 5 minutes. But there should not be so much handling at that site, just to have to irrigate through the running water. Then if it goes in the mouth, it should be spitted out immediately. If gone in the mouth, rinse the mouth for several times. And if you're wearing the contact lenses, leave them in the place and irrigate the eye. Once the eye is clean, remove the contact lens, clean them in the normal manner. So these are the do's. Then don'ts. Don't panic. Usually, as a healthcare worker, who is having knowledge about that particular disease and more knowledge, and again our mind will think that imaginary situation that he got infected and all those things will create the panic in the healthcare workers. So therefore, don't panic in the beginning. Don't place stick finger into the mouth reflexively. Again, more the handling, more the chances of getting infection spread. So therefore, don't put in the mouth and squeeze. Don't squeeze the blood from the wound. The expelling the wound, blood from the wound may again chances of again getting infection more. So don't squeeze the blood from the wound and don't use antiseptics and detergents. So these are the first aid precautions. They report to the designated nodal center. So every hospital must have a nodal center for management of needle stick injury. In most hospital infection control committee acts as a nodal center. On other hospitals may designate staff, clinic or casualty for the purpose. So nodal centers perform following actions. So subsequently the slides are given. The first dose of post-exposure prophylaxis. Take first dose of post-exposure prophylaxis. First dose of post-exposure prophylaxis should be taken as early as possible. Effect is maximum if it is taken within 2 hours. So therefore, it's very important. The fact is emphasized here that the healthcare workers should immediately report to the concerned authority, nodal officer of the needle stick injury, and report it so that he should appropriately get investigated and further guidance, further counseling, and be followed up with a timely manner. And if it is taken after 72 hours, then there is no time is gone now. No, after 72 hours, there is no effect. It has been documented that the post-exposure prophylaxis after 72 hours has no meaning. So it's not. So therefore, as far as possible, you should report to the nodal officer immediately. Then the NACO recommendation is there. fixed dose. Fortunately, fixed dose, single dose per day regime is there. That is TLD, tenofovir, lamivudine, and dolutegravir. So these are the three drugs. TLD regime. TLD regime is a fixed dose drug which is given post-exposure prophylaxis. If HIV negative status, there is no need of post-exposure prophylaxis. Meaning of this is if the source on which that needle was used on a patient, that is HIV negative, so there is no need of post-exposure prophylaxis. If status is not known, they take the first dose of TLD. Should be taken within 2 hours. So exposure cold, mild exposure, mucous membrane, non-intact skin exposure with small volume or very less duration. So that is a mild exposure. Moderate exposure is a mucous membrane, non-intact skin exposure with large volume or very long duration. Then superficial exposure with solid needle or superficial scratch. Exposure code 3 is a large volume transfer, hollow needle, wide bore needle, deep puncture, visible blood on device, needle used on patient's artery or vein. So these are the exposure codes. Then source code. Source code is positive, asymptomatic, and low viral load. So these are the three situations where that source code is 1. Source code is 2, HIV positive specimen, symptomatic with advanced aid and high viral load. Then source code is unknown, patient is not available for testing. Then HIV negative as per the NACO strategy. So the testing should be done as per the NACO strategy, and it should be declared as HIV negative. So these are the two things. One is the exposure code, and another one is the source code. And depending upon the situation, the action is taken. So you can see here exposure code, HIV status. So here exposure code is 1, 2, 3. Whatever the type of exposure is there, and if the source HIV status is negative, there is no need of post-exposure prophylaxis. If exposure code is 1 and if the source HIV status is 2, therefore all these exposure code is 1 and source of HIV status is 1. So here post-exposure prophylaxis is not warranted. Remaining things, if exposure code is 1, so there is a mild exposure, but HIV status is positive and with a high viral load. So you can see all the situations. Then 2, 2. 2, 1 also. There is a high that moderate injury, no moderate exposure, as well as the first is the asymptomatic HIV. So all these cases you can see in these scenarios, post-exposure prophylaxis is recommended, and duration of post-exposure prophylaxis is 28 days. Tenofovir 300 milligram, lamivudine 300 milligram, dolutegravir is 50 milligram. So it is given as a single tablet once daily for 4 weeks. So depending upon the exposure code and source code, the further post-exposure prophylaxis recommendation is done. Then patient post-exposure prophylaxis is not required in which circumstances? So exposed healthcare worker is HIV positive, refer to ART center. If exposed healthcare worker is HIV positive, so already is HIV positive, so we have to refer to the ART center. Exposure to intact skin. If the skin is intact, so there are no chances of transmission. So therefore, it's not required. Source is HIV negative. HIV negative source. So naturally, there is no need of exposure to the post-exposure drug. This post-exposure treatment, post-exposure prophylactic drugs. Then low risk specimens, as I told you, feces, sweat, urine, and all those low exposure species, low risk specimens, there is no need of post-exposure prophylaxis. Then exposure code 1 and source code 1 as shown in the table. So there is no need of post-exposure prophylaxis. Then source is unknown and HIV prevalence is a particular area, HIV prevalence is low and source is unknown. So in that scenario, post-exposure prophylaxis is not required. In case of delay in reporting more than 72 hours, already I told you it is a responsibility of healthcare workers to report to the particular nodal officer in that institute immediately, or if it crosses 72 hours, then there is a no use of giving any post-exposure prophylaxis. Then side effects and compliance. So when we are giving the drugs for 28 days, those antiviral drugs, so there will be so many side effects. So you can see nausea, diarrhea, muscular pain, fatigue, headache. So these are the general side effects. Then as these drugs are the bone marrow, they affect on bone marrow, anemia, leukopenia, thrombocytopenia. So these are the symptoms because of the uh, suppression, bone marrow suppression. For above, post-exposure prophylaxis should not be discontinued. And if jaundice develops only, it should be reviewed by the nodal person whether to continue or whether to discontinue. But remaining things we have to encourage. So here at this stage, counseling of the patient to continue the therapy, post-exposure prophylaxis therapy is very important. So support and counseling is also very important. Already the healthcare worker is in panic. So here the role of counseling and giving proper advice to continue, encourage the healthcare workers to continue the therapy is very important. If more than 95% compliance is there, it's okay, no problem. So more than 95% compliance is required to get protection. So healthcare workers should be counseled to continue post-exposure prophylaxis. So testing for blood-borne viruses. So we have to test the healthcare worker for blood-borne viruses, anti-HIV antibody detection, HBsAg detection, anti-HCV antibody detection, and anti-HBsAg antibody detection. So each is having importance for the testing of anti-HIV antibody detection. That means we have to detect the already whether the healthcare worker is infected or not. So if it is infected, then there is no risk. There is no role of hospital management for a particular situation. In HBsAg, the healthcare workers may be prior may be infected with hepatitis B. So in future, again he can't blame or can't to go in court against the hospital because of the infection because of health needle stick injury. Then anti-HCV antibody detection, then anti-HBsAg antibody. Anti-HBsAg antibody detection to detect the whether the healthcare worker is protected against acquiring infection of hepatitis B. Then decision on post-exposure prophylaxis. As per the NACO guidelines, we have to decide whether to give post-exposure prophylaxis or not. So here, informed consent and counseling. So whenever we are giving the drugs, so much toxic drugs, and we have to take for 28 days. So therefore, informed consent is very important. Counseling, the patient is in panic and already tense. So counseling and encouraging the healthcare worker for taking appropriate measures, the drugs, continue the drugs is very important. Almost every healthcare when feels anxious about the exposure, they should be counseled and provided psychological support. They should be informed about the risks and benefits of post-exposure prophylaxis drugs. Post-exposure prophylaxis drug is mandatory. If healthcare worker refuses to take post-exposure prophylaxis, it should be documented. So there is autonomy. It is the right of healthcare workers to decide whether he should take or not. So therefore, can't force the healthcare workers to compulsorily take. But here, the responsibility of the nodal officer or responsibility of infection control officer is to counsel the patient and document it and take the documentation that he is not willing for the post-exposure prophylaxis. However, he should be made to understand about the risk of acquiring infection if post-exposure prophylaxis is not taken. So, healthcare worker, if is not willing, the nodal officer or infection control officer should maintain the documentation format only. Whether I am accepting the post-exposure prophylaxis or rejecting, I know the risks and benefits. So, this documentation should be maintained in infection control office, HICC committee under the HICC committee, so that further illegal things can be avoided. So now you can see here the case study. Nursing staff working in corporate hospital was accidentally had finger prick while working in the ward. She reported to infection control officer immediately. She was counseled for post-exposure prophylaxis. However, she denied for taking it. Infection control officer tried to convince her with benefits of post-exposure prophylaxis and consequences of not taking. She was firm on the decision, but documentations about it was not maintained. After 6 months, she was tested for HIV and she was found to be reactive for the HIV. She went to court against the hospital for compensation. Ultimately, hospital had to pay compensation because no documentation was maintained in the hospital. Here, the healthcare worker had not given consent, and the nodal officer or infection control officer also accepted it, but documentation was not maintained in the good faith, and therefore, afterwards, the hospital has to pay compensation, and perhaps the healthcare worker that nodal officer may be fired. So, particular avoiding such situation, we have to maintain the documentation in the hospital. So what are the documentation regarding the exposure? Structured pro forma used to collect the detailed information related to the exposure, such as date, type of exposure, type of procedure during the exposure, source status, volume, and type of specimen involved. Then consent form for prophylactic treatment exposed to the person. The person must sign the consent form. If individual refuses to initiate the post-exposure prophylaxis, it should be documented. The designated officer for post-exposure prophylaxis should keep this document. So documentation is very important because to avoid any legal matters. Then follow-up testing. It's done if the source status is positive or unknown. So HIV we should test at 6 weeks. That means 1.5 months, 3 months, then 6 months. Then hepatitis B follow-up testing done at 6 months. So follow-up testing is very essential. So precautions during follow-up period. So if the source status is positive or unknown, refrain from blood, semen or organ donation, abstinence from sexual intercourse, breastfeeding to infants should be avoided. Any febrile illness, seek medical evaluation. Then post-exposure prophylaxis of hepatitis B. So till now, what we have seen, till post-exposure prophylaxis of HIV is seen. Now post-exposure prophylaxis of hepatitis B. So vaccinated healthcare workers protective showing the protective levels of anti-HBsAg antibody titers. There is no further action is needed. The healthcare worker is protected, so there is no further action. Only we have to counsel and uh, educate for behavior modification so that particular thing cannot happen. The needle stick injury cannot happen. But some type of healthcare workers are vaccinated, but titers is less than 10 international unit per ml. So here HBIG is given within 7 days and start second series of vaccination so that protective levels of antibodies will get antibody levels will get in the healthcare workers. And another group of healthcare workers might possible that they are not vaccinated or partially vaccinated. So there again within 7 days, HBIG should be given and complete vaccination should be started so that in future that healthcare worker will be protected. If healthcare worker is non-responder, if healthcare worker is not giving protective response, so HBI, hepatitis B immunoglobulin, which is a type of passive immunity. So two doses are given 1 month apart, 0.06 ml per kg or 10 to 12 international unit per kg. So this is given. So what do you mean by non-responder? Non-responder, these are those healthcare workers who are immunized with hepatitis B vaccine, two series of vaccination. So you know hepatitis B vaccine is given, three doses are given. If the one dose is given today, another dose is after 1 month, and third dose will be after 6 months of second dose. So this is one series of vaccination, and after 2 months of last dose, that is what we are giving after 6 months, where we have to test for anti-HBsAg titers. And if the titers are protective, that is 10 international unit per ml, then there is no problem. The healthcare worker is responder. If uh, the titers are less than 10 international unit per ml after 2 months of last dose of hepatitis B vaccine, again another series of vaccination is uh, continued. So three doses again given, and after 2 months of last dose, again we have to test for anti-HBsAg antibody titers. And if the titers are protective, it's okay. If the titers are not protective, that person, that healthcare worker, after two series of vaccination, should be considered as non-responder. And such non-responders should be documented if it is there in the healthcare worker. So such non-responders who are healthcare workers are exposed because of needle stick injury. So two doses of hepatitis B immunoglobulin is given at 1 month apart, 0.06 ml per kg or 10 to 12 international unit per kg. Then what are the important remarks? Healthcare worker protected if titers more than 10 international unit per ml after 3 doses. One or two doses is not considered. Healthcare workers is not protected. check for HBsAg status at the baseline. So whenever healthcare worker comes to the nodal person for testing, so we have to test for at the baseline and follow up testing 6 months later, regardless of the vaccination status. Anti-HBsAg only should be tested 2 months after the last dose of vaccine and 6 months after HBIG administration. Otherwise, it will give erratic results. HBIG provides temporary protection for 3 to 6 months. So HBIG is not an active immunization; it is a passive prophylaxis. So it will just give the antibodies. So therefore, there should be full course of vaccination in that healthcare workers. And HBIG provides only temporary protection, 3 to 6 months. Then previous report of anti-HBsAg titer should be documented. Only the reports, only the verbal communication should not be considered. So healthcare workers tell that I am having protective level. That is not sufficient. The document, the certificate, or that report should be required. Then previously protected person, the memory B cells will start producing antibodies soon after the antigenic challenge. Hence, revaccination by booster doses is not recommended even if the titer falls down later. So here you can see the case study. Here the failure of proper documentation again. So here healthcare worker had needle stick injury and source was positive for hepatitis B, negative for HCV and HIV. Infection control officer asked to check for HBsAg and anti-HBsAg antibody as a part of protocol of HICC. But healthcare worker was not willing to get tested. However, healthcare worker convinced the infection control officer that she is HBsAg negative and her antibody status is also protective levels after the vaccination. But documentation was not done in good faith. So after 1 year, she left that hospital and joined another hospital, but she was found HBsAg positive and blamed the previous hospital not taking proper care during working there. So this is a work-related injury, and she gone in the court against the previous hospital. And there was no record of this documentation of this particular incidents denied of this testing and all those procedures. So therefore, all the documents, the court asked that hospital to produce the documents whether she was convinced for testing. So she has not convinced, but it was with good faith. Document was not mentioned. So therefore, in this case, the doctor, the hospital has to pay the compensation. So here the importance of documentation is emphasized. So this is the last slide. Thank you for your patient listening. Thank you.